Hello and welcome to this critical care teaching video in which we are going to cover a brief introduction to ventilators and invasive ventilation. Before we get started, I just want to say thank you to the now retired consultant in intensive care from the East Midlands who, when I was struggling to get my head around invasive ventilation as a trainee, was able to demystify the subject fantastically for me. And a lot of this talk is based on his teaching. So to start with then, I'm going to give you a definition for a ventilator. We'll then look at a universal way of classifying ventilators. We'll touch briefly on how ventilators support the spontaneously breathing patient, and we'll look at the problem of the alphabet soup of acronyms that comes with any form of ventilation. So what is a ventilator then? Well, I would encourage you to define a ventilator as a device that allows the control of gas flow in two directions. And that's important, control in two directions. You'll see why when we come on to talk about the classification system. And for us, this really means in and out of a patient's lungs. So how are you going to classify them then? Well, one of the problems I ran into when I was training is the textbooks seemed so very confused on this topic. But you can simplify the whole system by asking yourself 4 questions. Firstly, how does the ventilator generate inspiration? Then, how does it cycle from inspiration back to expiration? How does the ventilator generate expiration? And that's why you need to remember that ventilator definition. And then finally, how does it cycle back from expiration to inspiration? So how does a ventilator generate inspiration then? Well, if you want to get flow of gas along a tube into a patient, you can either generate a constant flow of gas in mils per second, or you can create a constant pressure such that P1 is greater than P2, and therefore you get a flow of gas along your tube into the patient. And these are the only 2 ways that modern ventilators generate inspiration. It's either constant flow or constant pressure. So how about cycling then, from inspiration to expiration? Well, just think about what you do when you set a ventilator up. You enter a respiratory rate and you enter an IE ratio. And therefore, it's really clear that the only factor governing cycling in mandatory modes of ventilation is time. You have ventilators that might be limited by pressure or limited by volume delivered, but that's not the same as saying they're cycled by those factors. They are cycled by time. And while we're at it, we may as well cover cycling back into inspiration from expiration. Once again, the answer there is time. Now, how does the ventilator go about generating expiration? Bear in mind our definition. A ventilator is a device that allows the control of gas flow in 2 directions. And therefore, although expiration is for most patients most of the time passive, it is an active process for the ventilator. The ventilator has to allow the generation of a positive pressure relative to atmosphere to get gas out of the patient. As a result, it has to change P1 to make P2 greater than P1 and encourage gas flow from the patient. But cycling in spontaneously breathing modes is clearly not time-based, is it? We've all seen ventilators syncing nicely with patients taking spontaneous breaths. So what's happening here? If we look at pressure on the y-axis in centimetres of water against time on the x in seconds, in mandatory ventilation, the ventilator will cycle between top and bottom pressures based on time and time alone. But in assisted spontaneous ventilation, or assisted spontaneous breathing, or pressure support ventilation, whatever the mode term is for the ventilator you're working with, what the ventilator is doing is noticing these very small deflections away from PEEP. That's the patient trying to take a breath. Once the ventilator notices this, it will cycle into whatever you have dialed up as your assistance pressure. How does it cycle back then into expiration? Well, the ventilator starts looking now at flow. As the patient reaches the end of inspiration, the flow rate from the ventilator into the patient decreases, and when it gets to a certain point, the flow cycling target, the ventilator will cycle back into expiration and essentially peak. So what do all the acronyms mean then? Well, the thing you need to get your head around is that most of these acronyms are trademarked. BiPAP and BiLevel, for example, mean essentially the same thing, but they're trademarked by different companies. The exact same mode of ventilation may well have very, very different terminology depending on the ventilator that you are working with. And that's why it's most important that you can classify your ventilator, far more important than any of these acronyms. If we focus on inspiration only, you're dialing up a target inspiratory pressure or a target tidal volume. If you're selecting an inspiratory pressure, you are by and large working with a constant pressure generating mode of ventilation. And if you're selecting a tidal volume, you are working with a constant flow generating mode of ventilation. Now, as with everything, there are exceptions that prove the rule here. And in this case, you can have a constant pressure generating mode of ventilation that will give you your dialed up tidal volume, so-called pressure control ventilation with volume guarantee. So today we've looked at the definition of a ventilator, a universal means of classifying ventilators. We've touched on how ventilators can assist a spontaneously breathing patient, and we've delved in to the acronym alphabet soup. I hope you found this useful. If you do have any questions, please leave them down in the comments, and I hope to see you on the next video.